We're live. Welcome, everyone. It's 1 o'clock. What are we? Tuesday, May 5th here in Canada. It's May 6th already there in Australia. And look forward to talking to you today. I'm, of course, Bill Code, and this is my colleague, Kristina Mitz.
Hi, everyone.
Kristina Mitz works for Mount Canada, but she's a nutritional expert and advisor, and even does consultations, for us to help people. So when we start talking about somewhat more complicated things, to me anyway, such as SIBO, it might be really worthwhile to think about a consultation with someone with a skill set within it, unless it's incredibly complex, and then you're going to have to get to one of the very uncommon people around the world. So today we want to talk about SIBO. I just wanted to do a little bit intro prior to that, why COVID, of course, is a virus which attacks almost any organ system, okay? And particularly can attack the gut, especially the stomach and the small bowel, because they have epithelial cells which have these ACE2 receptors. But in keeping with that theme, those ACE2 receptors are also everywhere in our blood vessels because they're part of the endothelial, that's the lining inside the blood vessel. Part of the endothelial lining is ACE2 receptors. And that is why probably one of the two factors in that almost any organ system in the body can be affected. I have a colleague who's done a fair number of people, even young people, with rashes, unexplained, not seen before. Those are probably a local blood vessel injury secondary to COVID-19. So the other important one, and we've talked a bit about that already, COVID-19 is a huge problem increasing coagulation. So I suspect that is the cause of so-called COVID toe, which has been a new term everybody's been talking about in the last week or so. And this means that one of your toes is either turning black or dusky or blue. And the more likely thing is that hyperclotability, which is happening secondary to the COVID-19, is that there's a blood clot forming. It tends to land in the area supplying the artery to that toe or finger and causes that problem. And that may be an overlap. It's certainly the reason probably why we're seeing strokes in young people, because they've got COVID-19. Mm-hmm. And strokes in young people, 35, 45. That's really young people. Anyway, those pieces aside, that's why I still want you to read about Nattokinase, but it's also part of why we need to look at what increases our risk factor, because we're getting to a stage now, many states in the US and a number of provinces in Canada, and even New Zealand and Australia are starting to work more towards so-called back to normal. And everybody's doing that at a different stage in age. I think all of us that are kind of slow in the uptake, we're really hoping things work out well for those people who've done the pioneer ground of starting. We hope that they all do well, because that will increase the likelihood that we will get closer back to normal. So why don't you give a bit of an outline of what SIBO is, and because we weren't always talking about SIBO.
Sure. So SIBO is short for Small Intestinal Bacterial Overgrowth. So it's defined as there being an overabundance of microbes in the small intestine. So if we think of our digestive tract, it goes small intestine, then large intestine. The large intestine, or colon, is where we house the bulk of our microbiome, the bulk of our microbes. So we have tons and tons of microbes there. And the rest of the digestive tract is not sterile, but there is supposed to be less microbes the further up you go. But what happens during SIBO, for patients with SIBO, they have an overabundance of microbes in the small intestine, and it's actually defined as the presence of microbes greater than 10 to the 3. So that's the kind of the gist of what SIBO is. And then to take it one step further, we classify different subtypes of SIBO. So there is hydrogen dominant SIBO, there's methane dominant SIBO, and then there's hydrogen sulfide dominant SIBO. So those are the three different gases might be being produced while someone has SIBO, and we would test for that.
Well, sure. And as many of you have probably worked out already, there's certain bacteria produce certain gases, okay? And the classic one, and I know you're going to talk about more in a minute, is the methane production is from methanogens, right?
Mm-hmm.
So these are a subset. And then there's hydrogen sulfide, which is one of the gases. And almost everybody knows that from your experience maybe eating beans and then having nasty smelling, gas per rectum or farts thereafter, because that can dramatically increase due to certain substrates of, extra amounts of sulfur. And I think just before we do to that part, of course, is yes, we do have an oral microbiome. And if it's in really bad shape, that's going to be one of the precipitating problems to create a problem within the small intestine, or so-called helping aggravate SIBO. And the same at the stomach, a very big player in the whole scenario, because reduced acid secretion or medications doing that also upset that so-called normal bacteria within the small intestine. And I like it simple, because part of the problem with SIBO is certain bacteria becoming dominant.
Exactly.
The so-called pathogenic group. The same as it is in the large bowel, but just on a slightly lower scale, because it's normal to have a lot less than in the large bowel.
Yes, so there's definitely a combination of things happening. So like I mentioned, it's classified as an overabundance of microbes in the small intestine, but there's also this dysbiosis factor, so an imbalance of microbes, and there does tend to be more pathogens present than commensals or beneficial microbes.
Yeah, and so it's really important to have the small bowel working well. That's where the majority of things are absorbed for us. And if they're not being absorbed properly, that's part of the problem. And then the other thing, and we've alluded to this already when we've talked about leaky gut syndrome. And one of the downhill slides towards getting aggravating or more SIBO is a leaky gut. And so that's why, bringing all those pieces together and helping solve them, I think you and I appreciate it. It's a very holistic thing. You can't just say, well, I went to the doc, I got diagnosed with SIBO, gave me an antibiotic, I'm good. Well, it's not that simple, because it'll come back again likely unless you took away or solved some of the precipitating features. So how do we get into SIBO? I mean, I've got some theories as to why I got into it. I think you've had a challenge with it too.
Definitely. So mine started when I was living in Guatemala. I got an infection. I took ciprofloxacin, and then the onset of SIBO kind of occurred after that. So that's how it happened for me. There are a lot of different ways that SIBO might happen for someone. So it's like you mentioned, there are all these precipitating factors. So it might not be as sudden as, I had an infection and took antibiotics and ended up with SIBO. It might be a slower onset for someone. So it could happen over time gradually, because you have low stomach acid, you could have poor bile output, or you could have too much bile output. You might have something like Crohn's or ulcerative colitis, which makes you more susceptible. Celiac has an overlap with SIBO. Endometriosis does as well, because of the adhesions that are created. Traumatic brain injury impacts the migrating motor complex, so it's going to slow everything down and encourage overgrowth to happen in the small intestine. Anything that really slows down the migrating motor complex. So that would include medications.
Well, sure. And medications, the big one, many of us have been hit and might be a precipitating feature, is opiates or narcotics.
Exactly.
Because they're huge slowing of the motor complex. And so the motor complex, talking about it in that term, was kind of new to me. I mean, ever since forever, we talked about peristalsis. Well, peristalsis is one way of talking about the migrating motor complex. Okay, so we almost think of those terms interchangeably, although we don't tend to use peristalsis as much anymore. I think because people had trouble visualizing it.
Right.
It takes a really hyperdynamic peristalsis to see it. I mean, on a slim person, you can sit there and watch it, or you can take the large bowel and you can listen for, we used to call them borborygmi. I mean, these are big gases moving from one part to another, and you get to Noisy stuff. Porphyrism.
Yeah, so for anyone who doesn't understand what we mean by migrating motor complex or peristalsis, those are the cleansing waves that help to push everything through the intestines. And they are actually strongest in between meals. So one of the things you can do to help yourself if you have SIBO would be to create a window of 3 to 4 hours between meals, and then your peristalsis will be stronger. You'll have more sweeping motion through the digestive tract to clean everything out.
And that's been one of my issues. I've always been a major grazer. I think, well, a couple of reasons. First of all, maybe I wasn't absorbing things well. And I think celiac, even though I'm not formally diagnosed, I think that was one of the precipitating factors with my SIBO. But think of little tiny muscle fibers through all of the small intestine. And they need to work in waves to move things through. Not like cilia, that's not what I'm trying to represent, but they need to work in a pattern. And if they're kind of numb and not working, or maybe they're dumbed down because of narcotics, or as you mentioned, the traumatic brain injury. So now you're not getting the messaging from the brain, which helps coordinate and keep them going. And, you know, the other one, 2 diagnoses that come to mind with that is MS and Lyme disease.
Exactly.
Okay, because of course, now you're maybe not getting the messaging out to those peristaltic muscle waves. And so consequently, it's not moving well. And when it's not moving well, you're going to get potentially overgrowth of those certain bacteria, and sometimes not so good ones.
Well, maybe we should talk about what some symptoms are of SIBO. So if some of you are on here and thinking, well, I don't know if I have SIBO, I do have symptoms, well, you can kind of listen to us talk about some examples of symptoms and maybe some of our own symptoms. And I know there's a couple of people on here who do have SIBO or have experience with SIBO. So maybe you just want to write in what your symptoms are and we can relay those to everyone. So probably the most common SIBO symptoms are bloating and gas, and bloating to the point where a person looks like they're pregnant. So that's kind of like the classic SIBO. But it doesn't always look that way. Sometimes people will have SIBO and they don't have that extent of bloating. So they might also have a lot of food sensitivities. They might have a lot of brain fog. They might have skin issues. And then what would be some that you've experienced?
Well, you know, it's often either diarrhea or constipation. So I was in the somewhat easier to solve group, SIBO with diarrhea. I think it's harder to solve, and I know you'll get into that, SIBO with constipation. But as you can imagine, if you're slowing down the peristalsis and the things moving through, then in many cases, you're going to lend towards constipation. So maybe that's why it's easier to settle one than the other, and they tend to have their own different points. And I think the other part, I don't want anybody to feel left out if you don't have the symptoms of SIBO, but it's pretty common. 20% of the whole population have irritable bowel syndrome, and up to 70% of those may have SIBO. So that was the group I've in. I've had irritable bowel syndrome since my early 20s. You know, when the doctor palpated my abdomen, there was certainly tender spots, and I didn't know why, but it sure hurt. And it wasn't the liver, but it was the tissues over there because they were low-grade inflamed. And that's why I got the diagnosis irritable bowel syndrome. And then, of course, not to be confused, but there is a bit of a continuity. People often start with irritable bowel syndrome, and some go on to full-blown so-called irritable bowel disease, which is Crohn's disease and ulcerative colitis. And then celiac is a little bit betwixt and between, but it's certainly got its own set of issues. Exactly.
So back to the constipation and the diarrhea. So if you were to have hydrogen dominant SIBO, you're more likely to have diarrhea dominant SIBO. If you have methane dominant SIBO, you're more likely to experience constipation. And then there's going to be some people who alternate back and forth. And then with the hydrogen sulfide, it can also be one or the other. So you may find that you get diarrhea with the hydrogen sulfide, or you get constipation with the hydrogen sulfide.
Yeah. And so it was interesting because you did a great job of kind of summarizing things, and that will eventually end up at Dr. Bill Code, right? So people can go there for the summaries, and especially for the clinicians, there'll be, you know, connotations of, you know, which medicine you might use if you've cultured which bacteria. And that's, I think, especially in the methane group, isn't it? Because it's a little easier to treat the hydrogen dominant group in the diarrhea, but trickier to treat the other one. Although, and you'll be listing it there, right? Because sometimes we can do it with herbs. So you may not have to get a clinician to write you those things, but if it doesn't solve easy, it's a problem. So, and just before we, go a little further, I just wanted to reiterate that 20, and some people say almost up to 50% of people with COVID get some gastrointestinal symptoms. At least 20% do. And that may be diarrhea, because often when I'm reading them now, they're talking about all the symptoms, including loss of smell, loss of taste. They sometimes forget to talk about the gut symptoms. And that's unfortunate, because people are putting it down, well, it's just my SIBO flaring up. And yet you might really be going through a relatively mild case of COVID-19. And happily, 95% of those are relatively mild. It's the 5% that are the problem.
Mm-hmm.
Yeah.
Okay, well, do we want to talk about treatments, or do we want to continue to talk about root causes?
Well, let's spend a bit more time on root causes. I mean, one of my favorite pet peeves, and that's why I mentioned it in a chapter in the book, is protein pump inhibitors or antacids, because it's all kind of patterned to work well. If we get the oral microbiome working well, then we're not getting nasty bacteria being swallowed and going into the stomach and the small intestine. And that really matters, because stomach acid is one of our major protective things for killing a lot of the nasty bacteria that we might swallow, but it also dramatically pre-digests the food. So that links in. And so protein pump inhibitors, or regular use of antacids, or just getting older, reduces your acid secretion. So all of a sudden, what you might have been coping with pretty good, now in your 50s, 60s, 70s, it's flared up into a problem.
Right. Furthermore, with the stomach acid, so there are other medications that can reduce your stomach acid production as well, and those would include antihistamines. So histamine is actually required to stimulate stomach acid production. So if you're taking antihistamines, you're actually blocking that from happening.
And lots of people would do that if they're getting into allergy season, and we're into spring here in Vancouver Island. I realize it's fall and autumn in Australia and all difference. But, here, people, I got to go outside today. Going to be all these pollens. I better take an antihistamine. But everything comes with a cost-benefit ratio. So maybe I won't get so stuffy, but now I'll pay the price maybe with gut troubles.
There are also some minerals that are needed with stomach acid production. So magnesium, definitely. If you can check your magnesium status, that would be really helpful.
Yeah. And so magnesium, if you're trying to use it, and it's a good thing to have on your shelf for any number of reasons. Certainly for constipation, it's very helpful. But just, I'll say it and we'll say it again, because one of the helpful things is getting things moving through and getting that motor complex to work again. But just remember, even though it's great for treating constipation, magnesium, it doesn't help the motor complex. Okay? So it doesn't resolve that part. So it's important in the stomach acid angle and many other components in the body, especially antiarrhythmia and so on, but it doesn't help that mobility part of the small bowel, the peristalsis.
And I guess we can kind of take it step by step. So we've done the stomach acid. The stomach acid would then stimulate the production of bile by the liver. So when you eat food, you have the release of stomach acid. It starts moving into the duodenum, and then your body is stimulated to produce bile. So the liver is producing the bile. It releases some of that into the small intestine, but then it sends quite a bit of it to the gallbladder to be released more regularly throughout the day. So you do need bile production. This is one of your natural antimicrobial defenses that helps keep the small intestine clear of overgrowth.
Because the bile works, like the stomach acid, probably on a different set of bacteria. So it's another very much protective things, not just for bacteria, but also to some degree for fungi and even viruses. The one that we've gone a little bit by, but it becomes obvious to me in my old times in anesthesiology, because one of the commoner procedures we did on the gut was removing the gallbladder. And of course, almost any abdominal surgery, and as you mentioned earlier, the adhesions from endometriosis or the adhesions from previous surgery, Certainly, many gut or bowel surgeries can impact and really aggravate all the system working properly together. So those are, I think 40 to 50% of SIBO people have had a bowel surgery as one of the triggers. And I think number one has to be removal of the gallbladder. And just before I leave that, in case I forget the thought, of course, one of the triggers for aggravation of probably with the bile production is the liver well-being. So that's really messed up with glyphosate, okay, which also gave us the dysbiosis in the first place, but it also dramatically affects bile and bile production and bile flow with inflammation of the bile ducts. And so can precipitate the gallbladder being removed. And gallbladder being removed, even though we say it's not important, it's probably really important, like many things, tonsils, appendix, and so on. Better to keep all the pieces in if you can, and so on. So let's not forget about the surgical one, because some of you will have had some surgical procedure.
Exactly, and I would include C-sections with that as well.
Cesarean sections, absolutely, because adhesions happen post-cesarean section. And it's interesting because our immune system is kind of calmed down during the pregnancy, but it goes through a little up peak right after delivery. And cesarean sections around, you're going to have probably an increased likelihood for adhesion. So another good reason to have, if you can, a vaginal delivery.
We've even had folks come to the clinic who developed SIBO from trauma to the abdomen. So, for example, someone came and they had a snowboarding accident, ran into a tree, and that was enough trauma to stimulate the production of adhesions and prevent proper motility. Yeah,
because trauma to the gut, it's very real. You're going to get adhesions, because adhesions are the collagen formation and the fibrous formation that the body does in an effort to heal something. So the inflammation comes along first, and part of that, all the things come in, including the fibroblast getting that fibrin formation, and so then you can get adhesions from it. And adhesions are literally nothing more than that fiber going across, and now it's blocking things. And sometimes it can be a very unhappy scenario, because a bowel loop goes through a small hole in the fibrin, and then it gets locked off, and now you've got an emergency surgery sort of deal. So each of those are a problem, and it's always nice to say, well, we're going to go to surgery and we're going to lyse or break down the adhesions. Well, I'm hoping you've got control of other things too, or you're just going to get new ones.
And then we've got pancreatic insufficiency. So the less enzyme production you have, the more likely you're going to end up with overgrowth in the small intestine. And this can be both preceding and due to SIBO. So it's kind of like there's a snowball effect happening. So the SIBO may have come first, or maybe the pancreatic insufficiency did.
Well, in the pancreatic insufficiency, maybe I'm beating on that drum too much, but in the elderly, all those pancreatic enzymes are being reduced. And that's why taking digestive enzymes, which we'll talk a bit about in soon today, but that really matters too. And of course, the other thing that interferes with pancreatic enzymes and bile production, glyphosate.
So we haven't yet mentioned hypothyroidism or Hashimoto's. So that would be something that could slow down the migrating motor complex. As would diabetes. So diabetes can sometimes impact the migrating motor complex.
And we know it's really significant. For example, if I'm inducing anesthesia into a diabetic, I have to be extra careful to even protect the airway by pushing back in the airway as I'm putting a tube into the windpipe or trachea, because things move much slower in the diabetic gastrointestinal tract, because we've got injury of those small motor pathways, and so we're not getting the peristalsis occurring. So the two are, a double-edged sword.
And antidepressants as well. So antidepressants can actually reduce your stomach acid production, so I would count that. And then there are things like mold toxicity, or even viral infections that can impact your migrating motor complex. So
think COVID-19, because remember, it affects the gastrointestinal tract. So it can be an aggravating feature. And I'm not sure we mentioned specifically, but food poisoning. If you're unlucky and you're visiting somewhere, or maybe somebody has just left things out way too long in that summer picnic or whatever, but food poisoning can be an initiating trigger for the problem with SIBO.
Exactly. And then that would lead into the autoimmune type of SIBO. So you can actually develop autoimmunity from having food poisoning, where you end up producing antibodies to the toxins that these microbes are producing, and then that in turn impacts the migrating motor complex and slows everything down.
And so let's just take that a step further, because my personal belief is autoimmunity, and we now have some 400 diseases under autoimmunity, but reality, the kickstart feature, and the way you can calm many of them down, including the hypothyroidism you mentioned earlier, is to heal the gut lining. Because leaky gut, because we'll talk about it in a minute, LPS or lipopolysaccharide, when it gets into the bloodstream, or those miniature food particles which aren't supposed to get into the bloodstream, either one gets into the bloodstream, it triggers the inflammation cycle and pathway throughout the body. So SIBO people can struggle with depression, they can struggle with anxiety, as you mentioned earlier, the cognitive or brain fog, cognitive thinking troubles. So they tie in really close together. And you mentioned antidepressants. And of course, the old style thought was that antidepressants would raise our serotonin or raise our noradrenaline, norepinephrine if you're watching from the United States. But in reality, majority of that, I think 70% of serotonin is produced in the gut. And at least 50% of dopamine is produced in the gut. So the gut-brain connection is huge. And I think we talked about it a bit the other day when we talked about glyphosate, because glyphosate can trigger via the vagus nerve up to suppress the activity within the brainstem, okay? And so that's traveling through the vagus nerve, which the vagus nerve is also a road traveling for bacteria and other issues up to the brain, because the brain also has a microbiome.
The vagus nerve is also a pathway for LPS, or lipopolysaccharide, which is also it can be a causative factor for SIBO as well. Even though the SIBO might have been the thing that started your overproduction of LPS, LPS will perpetuate it. So the LPS does impact the migrating motor complex, and it's really important to reduce that during the treatment of SIBO.
At the end of the day, it's a tricky thing, whether it's chicken or the egg, because either one impacts the others and affects it along the way quite a bit.
This might be a good time to pause and look at some of these comments and questions.
Sure, let's do that.
Bruce says the LPS symptoms are the worst thing for him. So he gets bloating, gas, joint pain, brain fog, and mood swings. Yeah, that sounds like SIBO and LPS to me.
Sure, and I'm really sympathetic to LPS, because I've come to realize it's probably the reason many times, and sometimes it's worse after a fatty meal, because we know the fatty meal can sometimes aggravate the leaky gut. And the leaky gut, of course, makes pore systems so that we can get the lipopolysaccharide. So let's just back up. What is LPS? So I learned an interesting feature the other day. I'd learned back in medical school a very long time ago about the difference between gram-negative and gram-positive bacteria. Most of you will know that gram-positive group are Streptococcus, Staphylococcus, Enterococcus. Okay, so that's all well and good, and then most of the pathogenic ones are gram-negative. So what it is, it's a stain. One stains purple and one stains pink under this stain. But the key thing is, more of the gram-negatives are a problem for us because they're pathogenic or have an unhappy group within them. But the other piece I learned the other day, which was of interest to me, the reason they stain differently, gram-negative bacteria have a kind of a double cell wall. So that double cell wall, when the bacteria dies and breaks down, that cell wall forms into a little pocket or something. It's not super small, but it's a small group of molecules which are lipopolysaccharide. Okay, and that's where they come from, the death of gram-negative bacteria. If it all stays in the gut and passes on out through the bottom, all is well and good. But if you have a leaky gut syndrome or something aggravated the leaky gut syndrome, then you're going to get that surge of LPS after you eat. And that's probably why 20, 40 minutes later, I feel dozy. And if I have a large fat-containing meal, which I particularly like, and I do a lot of, because I don't do a lot of carbs, then boom, I pay the price because I'm going to get more dozy and nappy after. And that's due to the surge of the LPS probably going to the brain and triggering inflammation.
Right. So it's important to remember if LPS stays in the gut, then all good. But there are two ways that LPS can make it from the gut into systemic circulation. So way number one, leaky gut. Way number two is chylomicrons or through a really fatty meal. So those are the only two ways that LPS are going to make it into systemic circulation and bother you.
Yeah, yeah, but they're really key because this ties into many of the pieces in the book. It ties into the Alzheimer's chapter, probably ties into the MS issue, probably ties into the chronic fatigue, and it even ties into traumatic brain injury. Okay, because if the LPS is getting into the bloodstream and now you've had a traumatic brain injury, so a tearing of some of the vessels in the brain, boom, all of a sudden the LPS is through the blood-brain barrier and already affecting parts of the brain. And LPS, as talked about in Dr. Desai's article from the UK, 2016, Annals of Neurology, he talked definitively he could trigger MS in his animal model by injecting LPS.
Yep.
Really simple.
And again, important to remember, I know we're talking about gram-negative bacteria, but we don't necessarily want to demonize that entire group. So you'll remember in the first couple of videos we did on the microbiome, we talked about not demonizing specific microbes. If you're treating the microbiome or restoring the microbiome, you need to think about the terrain. So a really good example of this is to think of some of the hunter-gatherer societies that still exist. So in particular, there's been some studies done on the Hadza tribe in Africa. They have a much higher quantity of gram-negative bacteria that just live and are the normal residents in their guts, and they're not bothered by that. That's just normal for them. But because of how healthy they are, they're able to maintain that load a lot better than those of us in North America are.
And I think the other extension to that, a lot of the gram-negative bacteria, sure, they have the pathogens within them. But for example, most of the Clostridia organisms are fine. But if you get an overgrowth of C. difficile or Clostridium difficile, now you got a big problem. And it's the same with the E. coli. Most of the E. coli we handle fine, but some of them are just deadly as far as kidney injury. So if they get in a dominant group, or we get unlucky and get a big overdose of them in a bad hamburger source, then all of a sudden we're injured. And the same happens along with the Pseudomonas group. And many of those gram-negatives, there's only maybe 2 or 3 of them that are pathogenic, and they're not a problem if they're in very, very small number, and all the others are in a better equivalent with diversity. But it's when we lose the overall terrain and we get an aggressive group before, and often we've created a lot with an antibiotic series, or glyphosate, of course, another antibiotic.
Well, let's look at one of these comments. So Roger says, how can you tell the difference between fast peristalsis, nervous stomach, and SIBO? It seems that I'm passing my food through the digestive system really fast. For example, Imodium slows down the peristalsis, but I don't think it addresses SIBO. So,
let's start with the last portion first. So Imodium acts very much like a narcotic on the small bowel. And that's why, it'll put a cork in it, but a codeine will put a cork in it even better. So it's maybe slowing down the gut movement overall, but it's not enhancing the migrating motor complex. So a way of describing that same thing, one way to improve the peristalsis in some people's eyes, and one I'm willing to try and have tried myself, is LDN, low-dose naltrexone. Low-dose naltrexone, of course, is a narcotic or opiate antagonist, so it takes away the over effect of the opiates that are produced in the body. And so now you'll get better motility through the system. So even though we're anxious and nervous, it doesn't mean that we're necessarily solved our SIBO problem. So the SIBO, how can we best describe it? We know it's an overgrowth of certain bacteria. It's often interfering with the migrating motor complex. And then some of the other features that are in it. Anyway, anxiety does not always solve SIBO.
I would say, Roger, you need to look at the different root causes. So I can't really tell you if you do or don't have SIBO, but I can tell you that if you have really fast motility like that, there's probably something irritating your stomach or small intestine, or you have overactive parasympathetic nervous system. So I would wonder, do you have an overgrowth of some sort of pathogen in your gut? Have you done any form of microbiome testing or PCR-based testing to check that out? What is your bile production like? What's the stomach acid production like? So all of those different root causes that we were just speaking to, I would probably look into that.
And I think the other one that we must remember to look at is the mitochondrial function. Okay, because even if your cells are relatively normal, if they're not getting the energy production from their own mitochondria, so that would be people with fibromyalgia, chronic fatigue, or MS, all of these, or Lyme's, all with diminished mitochondrial function, all of a sudden things can't work well. And so that will be another reason that the motor complex or peristalsis isn't optimal, isn't normal. And a lot of us could also potentially had a go around of food poisoning that we maybe didn't recognize. We just put it up with it overnight or day or two, and then we were good. We thought, well, maybe that's a flu. Well, sometimes that's food poisoning.
Right. So the inflammation in the gut is going to impact the mitochondria, as would something like poor nutrient absorption, because the mitochondria need a lot of nutrients to work properly.
Well, and as a subset of that, the hypothyroidism, of course, because the mitochondria are partly regulated by the presence of the thyroid hormone, because it's the number one metabolic control in the body, and part of metabolism, or the rate of movement of energy in the body, is the mitochondrial function underneath the thyroid operation.
Okay, Sandra, what does marshmallow root do for our gut? So marshmallow root helps to coat and soothe the gut lining. So it can be really helpful for something like leaky gut. And it's also food for certain microbes. So it does act as a prebiotic for some of your beneficial microbes. So it's going to be positive in that sense as well.
That's an easy one to think about this time of year, because we had our grandsons visiting us and they like to do marshmallows. And so we all know if you get marshmallows hot and sticky on your fingers, it really coats them well. I know it's not the same thing, but it lets me think about it.
Yeah. Bruce, some doctors say that Pepto-Bismol will kill the H2S organisms. Any thoughts? So yes, that is one of the facets of treatment for the hydrogen sulfide, would be to use something like Pepto-Bismol, or you can get bismuth compounded as well. Yeah.
So Pepto-Bismol has bismuth in it, BISMUTH. Okay, and so that's often used. It's used to pack noses. Interestingly enough, funny yellow-looking stuff. But it's a fairly potent antibacterial against certain bacteria, and that's why I think it's used against the ones in the H2S organisms. That's why they're gone to it. So then our next question is from Ellie. Is a probiotic good to take?
Yes. So actually, you need to take specific probiotics with SIBO. A lot of the time, people with SIBO are really sensitive to probiotics because they already have an overgrowth of bugs in their small intestine. So I find that it's better to decide what it is you want to take the probiotic for, and then pick it based on that. So for example, if someone has slow motility, we can pick a probiotic that's going to help support their motility. So for example, one of the first ones I usually would start with would be the BioGaia, which contains L-reuteri DSM something. And that one is known and has been studied for its ability to improve motility and also its actions against gram-negative microbes. So therefore, that one is going to be probably really helpful for people with SIBO. It's also a single strain, so it's really easy to test out and know if you react to it, well, then it's that one thing. You don't have to worry about testing out this probiotic that has like 10 or 20 strains and not knowing which strain you're reacting to, if you are reacting.
And there's a bacillus strain too.
Exactly, right? Yeah. So I also like the Bacillus subtilis HU58 strain for SIBO because it does help to prevent circulation of LPS, for one thing.
Yeah, because if you can find the right combination of probiotics, just same as if you optimize your whole gut microbiome, you're going to reduce the leaky gut. You're going to reduce the triggering factor of the LPS. So well worth doing. Okay, so I have another question here from Roger, and this relates a bit to COVID. With mild COVID, can the diarrhea be one of the first symptoms before the fever? Well, yes, it certainly can. The tricky part is, and I think this is what you experienced, Roger, because not everybody is aware of that. Just like not everybody was aware of the lack of taste and lack of smell, and yet those can be really early. So the lack of taste and smell, the theory is that there's some involvement of the nerves supplying the taste center and going up through the sinuses. It's not very far. The cribriform plate is right at the top of the nose, short distance into the brain. When we're talking about the symptoms in the gut, most frequently it's diarrhea, but it can be cramping and abdominal pain, because remember, this can affect the stomach, the small intestine. Small intestine, this is the home of SIBO, so you can have some similar symptoms due to the COVID.
Mm-hmm. Yeah. Carla, what is the brand name of Nattokinase that you use?
Well, I've got two on hand currently. One is by AOR out of Calgary in Alberta, which I like as a Canadian because it's nearby. The other one has been Nadea, Nadai, actually. Okay, so that comes in a green bottle, so it's easy to spot, and it has a Canadian NPN number. And I know that it's available. For example, it's available from New Beginnings Labs, which is in Lenexa, Kansas, nbus.com.
Okay, Bruce, what supplements can counteract the LPS that gets into the tissues? Well, we just mentioned one, so the Bacillus subtilis HU58 is one. I haven't found a ton of research on this, but cinnamon is something else that can help prevent circulation of LPS. But then, of course, you're gonna want to get to the root of the problem, which if you have a lot of circulating LPS, then A, you probably have too many gram-negative microbes, and you're going to want to shift that population. And B, you're going to want to reduce the leaky gut, or not eat so many high-fat foods.
And I'm going to give you another of other suggestions, because LPS is also the trigger for a lot of inflammation sites in the body, including atherosclerosis, so injuring the heart, and injuring certainly the brain, injuring the gut and the gut lining. So we really want the bacteria breakdown product, which is the LPS, lipopolysaccharide, to stay within the gut, because the gut's our big protective feature. And so just to reiterate that, 70 to 80% of the immune system is based in along the gut lining, for the simple reason this is our biggest exposure to the outside world. The skin usually keeps things off, not always, but usually. And even the airways, as long as our air is pretty clean, then we don't have too many pathogens in through the airways. But it's really easy for foreign toxins or foreign microbes to enter in through the gut lining. So having a healthy gut lining is the whole deal. Hippocrates said, heal the gut and you will solve almost all medical problems. I think that's a paraphrase, but
yeah.
He said that a long time ago, and he was completely correct. The longer I practice medicine, I'm in 40 plus years now, the more I get it.
Yeah. And speaking of LPS and creating an optimal environment and shifting those gram-negative populations, so you can shift that population by eating a higher fiber diet. And so I know it's complicated when you have SIBO, because oftentimes you're using a low FODMAP diet or a lower carb diet while you treat the SIBO, but it's important at some point to come off of that and start incorporating more fiber so that you can build up your microbiome. And so that might be something that predisposed us in the first place to having SIBO. If we were using or on a standard American diet, which is high in processed foods, high in saturated fats, fats in general, trans fats, then we would have built up those populations of gram-negative bacteria in the first place and provided the optimal environment for them to live. So along comes an infection, or we eat some crappy food with E. coli in it, and now these microbes, this is the perfect place for them to live. So the main way to shift away from that LPS production, away from the gram-negative colonization, is to have a higher fiber diet.
And I don't suppose we're all into a high fiber diet right now. We're home quarantine, a lot more screen time, a lot more television time, and all of a sudden we're eating a lot more processed foods because we're fearful of all the problems thereof, or our lack of income or lack of employment. And all of a sudden, as our fear goes up, the immune system goes down and everything comes badly together. And all of a sudden we have more gut injury, not less, more. So that's why we've harped a little bit on it, but I can only reiterate it more. Get some relaxation techniques. That's a really critical one, whether it's the breathing technique I talk about in the book. Put some gratitude in your life. If it works for you, put some prayer in your life, but increase those components to allow you to get that balance between the sympathetic, parasympathetic. Each of these are going to make a very big difference to the gut and the gut lining. Quite frankly, when I'm getting irritated, I'm getting irritated in my gut now too. I'm in road rage because of that idiot in front of me. Well, I can't do anything about the idiot in front of me, but I can do my breathing technique, my 4-7-8, calm down, and I feel my gut relax. By the fourth breath, it's calmed down some. So we really need to be in tune with ourselves and try and learn that. This is extra hard for guys. I get that, but that doesn't mean we can't do it. Happily, women are more intuitive. They're more into yoga. And as you've probably heard, COVID-19 tends to worse affect men. And I think some of these are the reasons why.
Mm-hmm. So speaking of that overactive nervous system, there are a couple other methods that you can utilize as well. So hypnotherapy, gut-centered hypnotherapy is actually something that's used in studies to help reduce symptoms in IBS patients. And then hydrotherapy or cold hot water therapy is something that's also used. So if you're familiar with it, you've probably heard of Wim Hof. He goes around just jumping in glacier-fed rivers and lakes. That's one way to do it. You can also hop in the shower or the bath, and at the end, just turn it to freezing cold and try to withstand it for as long as you can. But if you are someone who's really sensitive to temperatures, then there's another way you can do it as well. So you can also take some cloth or an old t-shirt. You can soak that in the cold water, or even if you live in a hot climate, you can throw some ice cubes in it, wrap it around yourself, put a robe on over top, and then just go lay down in bed for at least 20 minutes. And then when you're done, take it all off and remove that. So that's actually really helpful for the parasympathetic nervous system as well. It's doing something like that. And then of course you would have the option of doing just a cold foot bath.
And I think what some of us learned this with MS a few years ago, because they would make, vests which would take cold packs from the freezer and you'd put it on, and then you could go outside and perform and act on a regular day, because people with MS or any nervous injury to a degree do not handle extra heat well. Mm-hmm. Okay, so that's another way to do it. And the other one that works really quite well, I've seen this in South American places, but they'll take a towel or a kerchief, put it in really cold water and put it on their neck. Because of course there's huge vessels in through here. So that brings down the core temperature very quickly and probably has some of that same benefit response.
Mm-hmm. Okay. Do you like PCR-based testing better than the 16S RNA sequencing? Well, I'll tell you the labs that I like to use. So I like to use Diagnostic Solutions GI-MAP, specifically for pathogens. They're really great for testing specific pathogens. I also like the Genova GI-FX. It's kind of like a middle ground. So you get some of the pathogens, some of the commensals, and you also get fungi. And then I like Thrive because it tests for the greatest number of commensal beneficial microbes. It's also the cheapest. Really, if you want to be thorough, you would use both Thrive and one of the other two options so that you get to see the pathogens and the commensals.
So just as a sidelight here, because unless you're a real wizard on your health and the gut, you might well want to, spend $100 and do a consultation with Kristina, for example, because it's a bit tricky to walk through some of these and understand what they mean. And you can go through a lot of money in a fairly quick period of time by the time you get into people helping you with the DNA testing and so on. So you want to have it optimally directed. Now, I don't think we've talked too much about diagnosis, but I guess we better go there because we're kind of slipping into the questions.
Right.
One of the others is a comment from Jody. She has bought an oxygen concentrator waiting for it to be shipped. I think that's outstanding because they're in relative short supply right now because of COVID-19, but for all the reasons I talk about in the book, for a lot of health issues, including the CCSVI I talked about a while ago, I think it's a really useful piece to have at home. And I think probably we need to, at one point, do another talk on sleep and sleep apnea, because that melds into the whole well-being of brain health and general health too. Yeah.
Mm-hmm. Okay, so for diagnosis, typically the gold standard is a lactulose breath test. So you would have your practitioner order the test kit for you. It gets sent to your house. You do a prep diet for a week, so really low carb, like chicken and rice, that type of thing for a week. And then starting 24 hours beforehand, you would fast. And then you go ahead and you drink this lactulose solution and then breathe into test tubes and cap them off. So you breathe into one test tube every 20 minutes for 2 to 3 hours, depending on the length of your test kit. And then you send it off to the lab. They measure the levels of gases and they let you and your practitioner know, is this person, what are their hydrogen levels like and what are their methane levels like? So the breath test only currently tests for hydrogen and methane.
And the tricky part is, it's been the gold standard, but it's starting to vary a little on that.
It is, yeah.
Because they've shown through some other tests that sometimes you can describe it differently. People may not be positive on a breath test. They still get symptoms. Then sometimes they'll do a jejunal collection. So jejunum, the duodenum is the first, foot, 18 inches of the small bowel, and then it's the jejunum, which is a fair distance of the 25 feet of small bowel, and you take a sample of bacteria from there and see what that is. So then they get a better idea, especially if they find a particular pathogen. And the advantage of that particular pathogen, sometimes that needs a specific group of antibiotics or herbs to treat it. And then you might be more home free. So yes, that's been the ongoing gold standard. I've been that route, you've been that route, but it's not foolproof.
Exactly.
So that's why a little bit, I want you to look at your holistic approach, all the pieces that you can do to feel better. And then by the time you're still accepting you probably have SIBO and it isn't showing on your gas testing, then it's probably time to move on and see a very good specialist at it. So someone like Dr.
Jacoby
or Dr. Jacoby in Australia. Australia's got some often better test kits even than we do in Canada, because I think there's been a great emphasis on SIBO and a lot of gut issues. And of course, that's the home of fecal microbial transplant with Dr. Barodi, which I prefer to call gut floral transplant. But, full points to the Australians, because they've looked at this for quite a bit longer and are more aware of some of the tricks in the trade to getting people better.
Yeah, exactly. And so, like I mentioned, the breath test is going to measure the hydrogen and the methane gases, but then what about hydrogen sulfide? So the common estimate for how many people do we think have hydrogen sulfide SIBO? Well, the experts are saying it's about 25%. But then when we look at these newer studies that are coming out that are kind of questioning the breath test as a gold standard, and they're using sampling of the jejunum, they're finding that it's actually maybe a lot more common than 25%. So that's something that's missed by the breath test for sure.
Yeah, and so I think we're getting better. And if you get someone that's very skilled in the discussion and discussion points, sometimes testing is important, but sometimes you can make a number of subtle changes and you will improve a considerable amount. I'm challenged with this. I finally got an appointment today. I saw my urologist, and I'm going to have a transurethral prostatic resection. Way much too information. I get that, but I have a bladder stone. So intermittently, I get a bladder infection and I get a kidney infection. And so intermittently taking antibiotics is not a good way to try and settle down your SIBO or anything else. So I got to get that problem solved, and then I can get more details to get that SIBO optimized, which is 2 years now since I think I discovered I had it.
Well, you have the benefit of having access to something like gut flora transplant. So if you do have to take antibiotics, you can replenish with the gut flora transplant, which is likely a really good idea if you're treating SIBO anyways. If you end up in a position where maybe you've done herbs for a really long time, or you've just taken too many antibiotics, you might find that you are depleted in microbes. And without that diversity, it's going to be really hard for you to come back. So
that's right. I've already done the gut flora transplant, and I'll do it again. And right now I'm trying to get probiotics to get me through this phase, but I know that I will have to do I'll do at least 5 days run. The original was 10, of course, but to get established and to, get that well. Because I realized if I can get all that working well and the reduced LPS or leaky gut, I'm more home free than ever.
Mm-hmm.
Yeah. And so mine was in the celiac. So we could go on. Let's see, we haven't talked too much about treatment. So I'll talk about my early, because it's the more simple treatment, and this is having rifaximin. So rifaximin is an antibiotic that tends to work mostly against the pathogenic and the bacteria in the gut. Happily, there's almost none of it absorbed throughout the body. So it doesn't get much liver toxicity, and it doesn't get absorbed into around the body. A little bit like mycostatin or nystatin in the candida thing. Probably we end up having to talk about candida at some point too.
Mm-hmm.
But rifampin for 2 weeks, and it's a prescription drug, and it works pretty well. And often 70-80% of people, if they've got that simpler type of SIBO with the diarrhea, they'll do pretty well. So that's, I took the simple one. So I'm going to ask you to talk about some of the tougher ones.
Yeah, so if you have methane dominant SIBO, and you were going the antibiotic route, you would probably take rifaximin plus neomycin plus a prokinetic. And then with the hydrogen sulfide, it really does come down to which microbe you're dealing with. So the rifaximin does not work for hydrogen sulfide. It can actually make hydrogen sulfide worse because it increases your bacteroidetes, which are bile tolerant, which often include the hydrogen sulfide producing microbes. So you would be more likely to take something like vancomycin.
So in this group too, as you probably alluded, collected from her suggestion, was you want to get the bile working optimally. Okay, so hopefully you still got your gallbladder. If you're not, you can't put it back in, so sorry. But if you can get the gallbladder or gall production or bile production working better, then that means, getting off the glyphosate, getting onto a diet, which is helpful, because a lot of bile circulates around and around the so-called entero or gut hepatic circulation. Okay, some of it goes right out the body, but a lot of it gets recycled and moved around again. So you want to have it working optimally. And the other one I missed in the go-around, non-alcoholic fatty liver disease, which is now even more common than alcoholic fatty liver disease. One of the big trigger factors, of course, glyphosate, but also high fructose corn syrup. Okay, so as I said before, I don't do soda pop, Canada, United States, because we always sweeten with that high fructose corn syrup. Nonsense.
Mm-hmm. Bruce says, I thought SIBO had to be brought under control before FMT. So yes, that's correct. We always tell our clients to get your SIBO under control first, but if you are doing a treatment, say you take the rifaximin and the neomycin and you've just wiped everything out and you've cleared the SIBO, that would be a good time to replenish with gut flora transplant, and then also specific diet so that you can encourage the microbes to come back that you want to come back.
So, and I think we've learned that a little bit the hard way, because we've been doing the gut floral transplants about 2 years, and the people who don't get the bounce great response are the ones that tend to have SIBO hidden underneath. So now we're trying to look at how can we optimize the whole package to help people solve both, perhaps at the same time, as you just said. So simplistically, someone like me, they've got SIBO diarrhea and they need the gut floral transplant for any number of reasons. Fine, get the timing right, make it work out right. We don't want to take the rifampin perhaps during the gut floral transplant, but you'll quit it a few days and finish it a few days before you start the gut floral transplant. And then you're doing the careful diet planning, which is now done with your therapist coach, because they're helping you work your way towards these diet choices. And then we're in a better scenario. So, we went down to Seattle to a major conference on SIBO, 4 of us, to learn more about it and understand it, because it's kind of the gut's a whole package. and dysbiosis in the small bowel, SIBO, dysbiosis in the large bowel, a whole host of things that lead to the colitis problem, or Crohn's problem, or the inflammatory bowel disease, or food sensitivity problem. But there's a lot of passover between the two, and we want the oral microbiome. So now we're developing a homemade toothpaste. Okay, so stay tuned. Maybe Mount Canada will have a homemade toothpaste soon.
Exactly. Bruce says, take rifaximin with partially hydrolyzed guar gum. Yes, so if you have the methane dominant SIBO, you're going to want to take partially hydrolyzed guar gums. We haven't hit on the herbal treatments yet, but partially hydrolyzed guar gum is definitely helpful for reducing the methanogens. It is also good to take it with rifaximin, because when you do the rifaximin treatment, it's actually good to be having some FODMAPs or some higher fiber things so that you actually encourage the microbes to wake up, and the rifaximin can be more effective. Rifaximin is also activated by bile, so you need to make sure that you have bile flow occurring at the same time.
Yeah.
We are at 2 o'clock, so I think we're going to have to stop, but I'll just read. This is a really nice comment from Roger. So Roger says, I've seen a couple of dietitians free as part of my MSP coverage in the hospital, and I've learned tons more here. Thank you. This is the kind of care I was hoping for in the hospital. Do you ever work within the MSP system?
Well, no, we don't, because we have learned, I've practiced medicine for 40 years, and more than 20 of that has been outside the system pretty much, because there isn't enough attention within the system. And the system, like all medical systems, it goes historically on its billing practices with what it's seen forever. So in something that's newly understood, whether it's gut floral problems or it's SIBO, it's not going to fit very well in the regular system, because the regular system can't expand to include something new. So that's my short summary on it. So that's often how it goes. And we wanted to give people the option to get well. And I guess the other option beyond that is to how to minimize your risk of doing badly with COVID. And I think we've talked about those a lot. Today, we've talked about COVID toe and how you might know what that is now and how you can avoid it. And also then how you can work on the SIBO problem. So I think on Thursday, we'll deal a little bit more with SIBO, because we haven't covered all the treatments. So if you've got questions, now is a good time to send them on in. If you know people that are troubled with gut problems or SIBO, maybe have them tune in on Thursday, and they can watch today's, of course, because it'll once again be at drbillcode.com. We're going to move it forward also so you can get it in audio only, in a so-called regular audio podcast format, because that might make it easier for some people when they're traveling or driving or whatever. I don't want you to watch the video while you're driving. That just doesn't work. It's not safe. So thanks once again for joining us. Thanks very much for joining us. It's a great discussion point. SIBO is a bit chewy. Don't hesitate to get some help with it. It overwhelmed me initially, and even a lot of family doctors, Canada, United States, they're not used to it. Whereas if you talk to the functional medicine, integrative medicine people, naturopath, osteopaths, physicians, then they'll be versed in it. That's what you need.
If you have any questions, feel free to write them in, and we can address them on Thursday. So go ahead and share this video with anyone who you think would benefit from it. That would be helpful for us as well if you could share it around. So that's it for today. We'll see you on Thursday.
Bye for now.